Welcome, everyone, and thank you for joining us for this important discussion on CAR T therapy and the hope it brings to children with neuroblastoma. For too many years, the prognosis for high-risk neuroblastoma remained unchanged, with limited advancements and few innovative treatment options. For families facing this disease, hope is not just a word. It's the driving force that keeps us going. Today, we stand at the forefront of innovation, witnessing breakthroughs that were once unimaginable. CAR T therapy represents a new era of possibilities, offering not just treatments, but renewed chances for brighter future. Together with science, determination, and unwavering belief, we move closer to the day where every child has the opportunity to thrive beyond this diagnosis. I am honored to have here today with us the amazing Dr. Del Bufalo to share her knowledge and advancements on CAR T clinical trials in Rome and also what's going out worldwide. Dr. Del Bufalo is a young scientist with interest in childhood malignancies, tumor immunology, immunotherapy, and hematopoietic stem cell transplantation. During her residency, she worked as postdoc for 2 years at the Center for Cell and Gene Therapy with Professor Brenner on CAR T and immunotherapy projects. Currently, she is the staff member of the Pediatric Hematology Oncology Department at the Ospedale Pediatrico Bambino Gesù in Rome. She coordinates the academic clinical trials with CAR T cells, hematology malignancies, and solid tumors at the OPBG, and participated in the preclinical and clinical developments of these approaches. She is the PI of research project funded by the Italian Ministry of Health to test donor-derived CAR T cells for the treatment of children and young adults with B cells acute lymphoblastic leukemia. Dr. Del Bufalo is a member of several international and national societies. She is the co-chair of the Cytopen CAR T working group. She is an active member of several neuroblastoma and leukemia committees. She is a new chair of European IBFM Resistant Disease Committee and the president of the Young Investigators sections of the Scientific Technical Committee of the Italian Ministry of Health. Dr. Del Bufalo is also an author of 90 manuscripts with an age index of 27. Dr. Del Bufalo, it's an absolute privilege to have you here with us today, and thank you for that. And I'm looking forward to your presentation.
Thank you so much. Thanks for this amazing presentation, and thank you for inviting me. It's a true honor for me to be here tonight. And let's get immediately into the topic. So as Annette just mentioned, I work at the Ospedale Pediatrico Bambino Gesù in the Department of Pediatric Hematology Oncology, led by Professor Locatelli. And just to give you a few numbers, to give you an idea of the structure where I work, which is a true privilege for me, it's the largest pediatric hospital in Italy, and it is very much focused not only in the clinical assistance to the patients, but also in developing side-by-side translational research. And indeed, they built a very huge research facility. It's a 5,000 square meter research facility, which with labs that cover all the different pediatric fields. And Professor Locatelli, when he moved to Ospedale Pediatrico Bambino Gesù, he started to develop a cell and gene therapy program for pediatric tumors back in 2014. And with the aim of developing CAR T cells, the hospital developed a 1,300 square meter GMP facility, where we now have 8 clean rooms for gene therapy products, 1 room for vector production, and 1 room for vector purification, which allow us to produce a very high number of drug products for the treatment of our children. And this facility has been approved back in 2017 for gene therapy products. And so this is, and all these amazing infrastructures and amazing projects are what give us the possibility to move forward to the clinic, all the projects that we have the chance to manage. And just a brief introduction for those of you who may not be familiar with the concept. CAR T-cell belong to the field of immunotherapy, which is in general a treatment option which it's aimed to harness the ability of the body's own immune system in order to recognize and attack cancer cells. The concept may be quite new, and it starts from a quite old instead observation, which is the process of the continuous immunosurveillance in our body that is taken out by the immune system. The immunosurveillance is a very refined mechanism by which different players in the immune system continuously control our body, and when they find any cell that it's becoming to have a tumoral behavior, the cells of our immune system normally are able to eliminate that and to induce what is called the tumor suppression, which is the normal condition. But for reasons that we still don't know exactly, in some patients, this phase tend to get to move towards a sort of equilibrium in which the cancer continues to form, the immune system is able to control its growth, but not to completely eliminate that. And in that phase, it's the preclinical stage where we have the so-called cancer dormancy. At this point, we have two options. Either at a certain point, the immune system prevails and the tumor gets eliminated, and we go back to the elimination phase. But unfortunately, in some other cases, and these are the patients that develop the disease, the tumor continues to grow and overcomes the ability of the immune system to control it, and we get into what is called the escape phase or the cancer progression. Well, all this is very important because it has been the base for developing immunotherapy, and immunotherapy contains different strategies that I will just show you in a second, but all of them are aimed at going back from the escape phase to the elimination phase, in which the immune system is able to control again the disease and eliminate that. What are the advantages of immunotherapy over conventional treatment? There are several. I will not spend much time, but it's just to give you an idea that it's a completely different way of thinking at how to attack the tumor. And this is really one of the reasons why I was really intrigued by immunotherapy since when I was back in my medical school studies. And there are several reasons, as I was mentioning, several advantages. First of all, the activated immune cells are able to recognize and target also remote areas of the cancer, which normally cannot be attacked by surgery or often not even by chemotherapy. And then another advantage differently from chemotherapy and radiotherapy, the stimulated immune cells are not able to target only the cells that are rapidly dividing, and this is the basis of the working system of the different chemotherapies and also of the radiotherapy, but they can act also on resting cells. And since we know that cancer stem cells normally are resting cells, this is extremely important if we want to aim to a complete eradication of the disease for long term, which is then what we call the cure of cancer. Moreover, the specificity of targeting of the cancer cells by the immune system it's much higher than the conventional treatment like chemotherapy, immunotherapy, and radiotherapy. And immunotherapy is able to attack the cancer cells, leaving the surrounding healthy tissue intact. And this leads, of course, to fewer and less devastating side effects, especially long-term side effects than traditional therapies. And we all know how much burden of sequelae our children needs to face along their life if they survive a cancer. And last but not least, another very fascinating concept is that the immune system is endowed with some cells, which we call memory cells, which are able to keep a memory of what they need to eliminate, and in this case of cancer. And what is the advantage of that is that even after years, if these cells encounter again a cancer cell that it's trying to give a relapse, they are able to attack them and eliminate them even after a long time after the treatment. And this is definitely something very fascinating of this approach. There are several immunotherapy strategies, and this is just to tell you how much the research is really focusing their efforts on developing this immense field, because it really holds true potential for our patients. And I will obviously now focus on CAR T cells. CAR T cells, I will not go through the details of these cartoons because it's way too complicated, but this is just to tell you a few concepts. First of all, the way our immune system works, it's incredibly sophisticated, which means that leads to a very strong power of our immune system on our side, and this is really one of the miracles of the nature. But on the other side, this makes it very complicated to interact with the system in order to create some drugs. And the way CAR T cell work is by combining the activity of the T cell function, which are the most powerful amongst the most powerful killers of our immune system. But as you can see here, they require a very complex system to be activated and ultimately lead to the killing of the cells. The CAR T cell combine this incredibly strong activity with the simplicity of a monoclonal antibody. As you can see from this other cartoon on the right, a monoclonal antibody immediately targets the cancer cell and eliminates that. And the combination of these two advantages of these two cells, it's what it's at the basis of the creation of a CAR T cell. And what is a CAR T cell? A CAR T cell is a T cell in which we introduce by different systems, generally viral vectors, a transgene that we create in the lab, which is composed by the fusion between the single chain variable fragment of a monoclonal antibody, which is the part of the monoclonal antibody that is able to recognize a target antigen, together with the zeta chain of the TCR of the T cell, which is the machinery that is able to induce the activation of the T cell. And what we obtain with this fusion molecule, it's a new molecule, which is called CAR, or chimeric antigen receptor, which is able to recognize the antigen that we want without having to go through all the complex mechanism of activation of a T cell, which is called the MHC class 1 system. But at the same time, it's able to activate the strong potential of the T cell, which is expressed by these two molecules that I marked here, granzyme and perforins, whose ultimate activity is inducing the cytotoxic killing of the tumor cells that we have targeted. So in few words, with this strategy, we can target the cells that we want as long as we identify the antigen to attack, and in the case, for example, of our CAR, the antigen is the GD2, and at the same time activate immediately the killing potential of the T cell. But how does it work practically beside the theory, the approach that we are talking about? So most of the cases, not all of the cases nowadays, but most of the cases, the approach is an autologous approach, which means that it's activated using the T cells of the patient itself, which are collected through a process that is called leukapheresis. So the blood of the patient goes through this machine, which is able to take out the mononuclear cells and reintroduce the rest of the blood into the patient. Then these cells are activated in the lab, are sent into a specialized lab, a GMP facility, the one that I just talked to you about, which is a very specialized lab in which we can create new drugs from the cells using also gene addition techniques like this one. And in this lab, what they do is they activate these cells, they introduce the gene through different systems. In our case, it's by using a virus. This gene introduced into the cell, it's able to produce the protein, which is the CAR expressed on the surface. At this point, we have a lot of T cells that are expressing the CAR. We let them in culture so that they can expand and reach high numbers. And then we can freeze them down or administer them fresh, depending on the protocol that we are using. Normally, before administering the CAR T cell, we give low-dose chemotherapy to the patient, and this chemotherapy is not administered, of course, to give an activity against the tumor, because when we get to CAR T cell, normally we already had a failure of chemotherapy. But the reason for administering this chemotherapy, which is called lymphodepletion chemotherapy, is to create the right homeostatic space in the body of the patient to let the CAR T cells have the space to grow. And at that point, after chemotherapy, the T cells that have been modified in the lab are infused back into the patient. At that point, they go around the body, they patrol all the body, and as soon as they find a cell that is expressing the antigen which we had chosen, for which we have created the CAR, they attack the cell, they eliminate the cells, and at the same time, they get activated and they give what is a classical symptom of inflammation, like the symptoms that we have when we get, for example, a flu. And this is the main toxicity that is induced by CAR T cell. It's called cytokine release syndrome, and it's related to the high release of these inflammatory proteins, which are called cytokine. This normally occurs between 1 and 10 days after infusion, and is characterized by, as I was mentioning, inflammatory signs. First of all, fever, which is a hallmark of CRS, and then a feeling of malaise and fatigue. And when it gets more severe, it can give also hypotension or either cardiovascular failure or respiratory failure in the worst, most severe cases. Other typical toxicity which are associated to the inflammatory storm that it's induced by the CAR T when they are activated, it's represented by the cytopenia, so the reduction of the blood counts in the patients that sometimes can be prolonged, and it's very commonly associated to all types of CAR T cells. And another important toxicity, it's again related to the inflammatory storm, but it's involving especially the brain, and it's called the neurotoxicity, which usually occurs slightly after the cytokine release syndrome and can go from very mild symptoms like migraine to very, very stronger manifestation like epileptic seizures or global encephalopathy. And last but not least, another toxicity that can be associated, especially with GD2-directed CAR T cells, it's pain related to the activation attack to the terminal fibers of the nerves. Of course, these are all important toxicities, and CAR T cells are a treatment that can be associated with important toxicities. And this is why a multidisciplinary team, which is trained and experienced on the management of CAR T cells, needs to be involved when a patient receives CAR T cells. But these are all acute toxicities, which nowadays we have become more and more able to manage, so that the sequelae of this treatment are normally zero. And CAR T cell, as you know, have been developed initially for the treatment of hematological malignancies, especially leukemia, but also lymphoma. And that's definitely the field where they have found the highest success in the world. On the other side, the success in the field of solid tumors have been lagging behind, and I will not go through the detail of this slide, which is very technical, but it's just giving you an idea of how complex a solid tumor is, because it has a very complex three-dimensional structure by itself. And as you can see, there are different players, not only tumor cells that are playing in pivotal roles in the growth of a tumor, like fibroblast matrix, different molecules that are inside the tumors, and also the vasculatory structure. And all of these have a depotentiating activity on CAR T cells. And this is why conventional CAR T cells normally in the solid tumor field have been failing. And based on this knowledge, at the Bambino Gesù Children's Hospital, when we decided to invest in solid tumors, first of all, we decided to invest in neuroblastoma because we know that this is one of the biggest challenge for the pediatric oncologist, and it's one of the deadliest disease for our patients, and we definitely want to improve the chances of cure for our patients. And being aware of all the difficulties that we were going to face in a solid tumors and in a challenging tumor like neuroblastoma, we decided to create a, let's call it, more powerful construct in which we included two small protein parts, which are called the co-stimulatory domains. In particular, we included 4-1BB and CD28, and these are two molecules which are able to provide more strength to the activation of the CAR T cells once the CAR T cell encounter their antigen. So they create a more powerful CAR. Conventionally, what the other CAR T cells that have been tested in the clinic normally are second generation CAR T cells, so they contain only one co-stimulatory domain. But since we had to face this important challenge, we decided to put two co-stimulatory domains to push the activity of the CAR T cell more. But of course, we were wondering when we were building up our project, what if the CAR that we are building becomes too strong and too powerful, and it turns into something that can give damage to our patients because it's giving too much of the toxicity that I just mentioned. And so to be on the safest side and be sure that we were able to control our CAR T and not to give too much risk to our patients, we decided to include a second gene, which is called the suicide gene, which is essentially a switch in our cells that we are able to activate whenever we need by giving a different compound, which is called rimidoside. And when we give this compound, rimidoside, the CAR T cell immediately dies. It goes into what is called scientifically apoptosis, which means that the cell dies. And this leads to the immediate shutdown of the activity of the CAR T cell. Of course, the activation of this system has the backside of blocking the anti-tumor activity of the CAR T, so it needs to be used only when extremely needed. But on the other side is a very powerful tool to control the toxicity, and we decided to include this in our construct. And as you may know, nowadays, it's already a couple of years ago, we performed our first interim analysis of our trial, which has been published in the New England Journal of Medicine. And in this part of the study, we analyzed the patients that were treated in our clinical trial, especially those patients that were treated in the phase 1 portion of the trial. The phase 1 portion of the trial is what is called the dose finding portion. And basically, when we get into the clinic with a new product that we don't know absolutely how powerful and how toxic can be, we need to start treating the patients from lower doses to be sure that we don't give too much toxicity, and then we can slowly increase the dose up to the dose that we think it's giving enough clinical activity without giving excessive toxicity. And this is what we did in the phase 1 portion of the study. And with the possibility, we started from 3 million of CAR T cells per kg of the patient body weight, and we had the possibility of reducing the dose in case we were observing too much toxicity, or increasing the dose in case of the absence of toxicity. And we also analyzed in the paper that we published a couple of years ago, the first few patients treated in the phase 2 portion of the study, which is the portion of the study in which we have identified our recommended dose, and we start to see what is, in a larger cohort of patients, what is the true activity of that dose. And all of our patients received a lymphodepletion chemotherapy, which was based on these two drugs, fludarabine and cyclophosphamide, then 2 days of rest, and then the infusion of the CAR T cells. This is just to give you a short summary of what we had found in our paper. We had treated 27 patients, 9 in the phase 1 and the remaining 18 in the phase 2 portion of the study. And if you look at the characteristic of these patients, they were heavily treated because they were having a median of previous 3 lines of treatment, including the first line that, as you all know, it's a very heavy combination of treatments. So these patients were all heavily pretreated children, and half of them were having a relapsed disease, and a quarter of the cohort was having an amplification of the MECAN oncogene. So first of all, of course, we wanted to know whether we were able to produce the CAR T cells for our patients, because the first thing was to understand whether from the lymphocytes of these children we could obtain the cells for our patients. And as you can see here, we were able to obtain a median of 2 billion of cells, of which 72% were CAR T cells, so very high numbers of CAR T cells at the end of manufacturing, which allowed us to have multiple doses for each patient enrolled. And in terms of toxicity, we observed actually the typical pattern of toxicities that are associated with CAR T cell. We had severe hematological toxicity in all the patients. We had in 20 patients cytokine release syndrome, which was actually severe only in one patient. All of the other patients had only fever and mild requirements for oxygen, and none of the patients in this first cohort of children developed central neurotoxicity, or how we call it nowadays, an ICANS. And so based on these results, we didn't observe any toxicity that was requiring a reduction of the dose, and therefore the recommended dose for the phase 2 that we have set was 10 million of transduced CAR T cells per kg of patient. And the results of the first cohort of patients that we were treated were remarkably surprising for us, because we were able to obtain 9 complete remission in 9 children, and 8 patients, a partial response, but 3 out of these patients had a negative PET scan, and in one of them we also were able to perform a biopsy and observe that actually what we were still seeing in the MIBG scan was actually differentiated disease. And I'm very happy to tell you that all 3 of these children are still alive with exactly the same stable disease, which we now can say that it's not disease anymore, but it's just differentiated tissue, because they are now 5.5, 4.8, and 4.2 years after treatment. And so we can say that or that they are cured, or the chance that they are cured is very high. So very, very promising results, which translates in what we call an overall response rate of 63%. But what does it mean in terms of survival? This means that the possibility for a child that receives CAR T cells in these conditions to be alive without disease 3 years after infusion, it's in the order of 36%. And for us, this result was already very encouraging, considering that for patients with relapsed refractory disease, historically, the possibility of being free of disease 3 years after treatment has always been below 10%. So it was already more than 3 times what we were used to see in this kind of patients. But this was not enough for us. We really wanted to understand how we could improve further the results, and to understand that, we really wanted to understand, and we still want to understand as much as possible, who are the patients that can benefit, and so that we can take the patients to that condition and improve the cure rate of our kids. And so we were really studying our patients to understand this. And what was striking for us when we were treating the children was that the amount of the disease that we were having at the moment at which we were giving the CAR T cells incredibly was giving a different outcome of the patient. In other words, when we were giving the CAR T cells to a patient that had a disease under control with the other treatment before infusion of CAR T cells, and the disease went below a definite threshold, which we identified, and it's simplified here in the cartoon, well, these patients had a much higher possibility not only of responding, but most of all of maintaining the response over time, which is what we really want to obtain, of course. Whereas the patients that were treated with a high disease burden, which means a high load of disease at the moment of infusion of CAR T cells, well, even though we were able to observe complete remission in these patients, invariably those patients were then having a relapse of the disease, which was then unfortunately leading to the death of the kid. And so we understood that to improve and have the maximum potential from our CAR T cells, we definitely had to pre-treat the patients and give them, lead them to achieve a low disease burden that was able to give the CAR the maximum chance. And when we were doing this, the chances of having a 3-year event-free survival, which means being free of a disease progression or relapse 3 years after the treatment, was increasing slightly above 50%. So we have now, of course, continued treating our patients. We have completed the enrollment of the study, but we have kept treating the patients. I will show you in a few moments how we are treating the patients at the moment outside of the clinical trial context. And this is the summary of the characteristics of the patients in our updated cohort. We have reached 49 patients. Actually, we are now even beyond this number, but at the last analysis that we did, we had reached 49 patients. Again, a heavily pretreated cohort of patients, and this again will probably change in the future, and I will show you how important it is to treat the patient early. Again, 30% of the patients were having a MYC amplification in their disease. Importantly, considering the importance of treating with low disease burden, we had then increased the cohort of patients that we treated in non-evidence of disease at the end of the first-line treatment. And you may wonder why we wanted to treat patients in non-evidence of disease at the end of the first line. Well, as you probably already know, the long-term survival of these patients at the end of the first line, it's 60%, which is good, but it's not still ideal, because it means that 40% of the kids will have a relapse of the disease. And already this would be enough to say that we need to improve already the first line to give more chances to the patients. And we already know that the earlier we act, the better the outcome of our patient. And so, first of all, we wanted to improve this. And second of all, 60% of maintaining response refers to a subcohort of patients, but we all know that there are some children that unfortunately have some characteristics during the treatment and of their disease, which are telling us as oncologists that these children are at even higher risk of having a relapse of disease. And we know now some of these factors. And so what we decided to do was, what if we give these children more chances not to relapse after the treatment? And so we decided to treat patients that were having what we call an extreme high risk of relapsing after first line, to give them a further consolidation, like maintenance with dinutuximab, so after that with CAR T cells, to see whether these patients were having less chances of relapsing. And these are what I just showed you. So again, we were able to prove that our manufacturing is very strong. I will not go through the technical details, but this is just to tell you that the cell numbers that we are obtaining at the end of manufacturing is extremely high and able to give multiple doses to all the patients. The toxicity that we observed in our cohort, even in the updated cohort, is similar to what I just showed you in the previous cohort. So mostly severe hematological toxicity and mild cytokine release syndrome. But in this updated cohort of patients, we have now seen up to grade 3 neurological toxicity in our children. And for these patients, as I will show you in a moment, we have used our suicide gene to be sure that we were not giving any damage to our patients. And this is what I just mentioned. These are the 4 patients that develop grade 3 ICANS or neurotoxicity. And for all of them, we gave steroids to reduce the activity of CAR T cells. But since we were seeing that the patients were not recovering fast enough as we wanted them to recover, and all of these patients were unconscious at the moment of starting the steroids, they were developing this very rapid loss of consciousness. We were, of course, very worried for our kids. So we started steroids, and as soon as we didn't see an immediate effect, we decided to activate the suicide gene by giving the remidoside. And as you can see from this graph, This graph represents how the CAR T cell grow and how they go down. As soon as we administer the remidoside, represented by the blue arrow, the CAR T cell immediately drop. But what is even more striking, but unfortunately I don't have anything to show you this, but to our eyes was really striking, was the clinical activity of this system, because all of the 4 patients, few hours after administration of the remidoside, went from being completely unconscious to wake up spontaneously, so to recover a normal level of consciousness really within few hours, which is incredible. And as you can see, what was also striking and important for us was to see that although the remidoside was reducing dramatically the counts of the CAR T cells, it was not eliminating the CAR T cells completely in any of the patients. And in some of them, as you can see, we had also a regrowth of the CAR T cells sometimes after the activation of the suicide gene. And importantly, all of these patients are still in complete remission, even long time after infusion of the remidoside. So all of these patients are still benefiting from CAR T cells. And these are the updated results in the cohort of patients that we have now treated. We have now 33 patients that are treated at the recommended dose with the low disease burden that I mentioned before, or immunodeficiency of disease. And out of these 33, we have been able to observe a response, either CR or PR, in 27 of them, including 7 patients that were already treated in non-evidence of disease. And this leads to an overall response rate of 82%. And most importantly, we have now updated our cohort and have an updated follow-up. And we can now say that if we treat our patients with these characteristics, the possibility for them of being without disease and without events of disease 5 years after infusion is in the order of 60%. So we are very happy with these results. But of course, again, we are happy, but we are still far from our goal, which is curing all the patients, which is our dream. And so we need to really understand what are the factors that are impacting on the activity of CAR T cells. And so we wanted to see whether the type of disease, whether it's a relapsed or a refractory disease, which is considered to be able to impair the outcome after other treatment for patients with relapsed refractory disease. Well, in our cohort of patients, we didn't see a significant difference in the possibility of survival between these 2 groups of patients, meaning that both refractory and relapsed patients can respond to the treatment. We also wanted to know whether the previous treatment with the monoclonal antibody targeting GD2 could in some way impair the activity of our CAR T cells. But as you can see, we don't see a significant difference between these 2 groups. And also the MECAN amplification, which we all know to be a very important prognostic marker for our patients, actually does not impact on the activity of CAR T cells. But what we found important in impacting on the activity of CAR T cells is when we give the CAR T cell. If we give CAR T cells to a patient that has already received 3 or more lines of treatment and none of them has been able to work, well, the possibility of being alive long-term without disease, it's significantly lower than those patients that are treated after 1 or 2 lines of treatment. So the message here is the earlier, the better. And this is extremely important for us, because the more the disease receives treatment, the more we select resistance mechanisms that are also able to impair the activity of CAR T cells. I will go very quickly on the last slides. As I mentioned before, we have treated 7 patients in non-evidence of disease at the end of frontline. We have a median follow-up of 15 months, and out of these 7, only 1 patient relapsed. And we have now 2 patients that are 5 years after treatment and they did not relapse. So we still need longer follow-up, but we think that's having 6 out of 7 patients with this kind of disease still alive, it's an important sign. We also treated 4 patients during the first line treatment because of a relapse or a refractory during first line, and they all responded to the treatment, with only 1 patient who relapsed after the treatment. And so in conclusion, I can tell you that the GD2 CAR-T01, which is our product can be manufactured successfully for these children, it's associated, the treatment is associated with specific toxicities that can be managed if we have the competence to manage them. The suicide gene is definitely increasing the safety of our approach. And importantly, the low disease burden at the moment of infusion is crucial to improve the probability of long-term survival. With this in mind, our CAR T cells are associated with a strong anti-tumor activity, as I showed you before, but still we need to improve the approach. And we know that an early treatment is associated with improved chances of achieving the cure. And at what point are we at the moment with our project? We are, as I showed you in a second, developing a new trial. But in the meanwhile, given the high number of requests that we were having and given the potential that we know from this therapy, we keep treating our patients thanks to the possibility by the Italian regulation to treat them under hospital exemption, which is a single patient approval by our regulatory authority. So it's a very time-consuming process because we need to discuss every patient with our regulatory authority and have the approval for each one of them. But this is giving us the opportunity to keep treating our children, and we are very grateful to the Italian National Competent Authority for allowing our children to be treated with this treatment. The only problem with this approach is that they give us the approval for the treatment only in Rome, so the patients need to be in our hospital, and so they need to travel to Rome. And logistically, currently, it's a two-step process. In the first step, we collect the cells, and this takes a 2 to 3 days stay for screening procedures and collection of the cells. Then the patients go back to their treating centers if they're not coming from our hospital, where a bridging strategy is agreed together with the treating physician of the hospital that is referring the patient. And then in the step 2, once the cells are ready, normally between 1 month and 1.5 months after collection, and are released and the treatment is approved by AIFA, the patient comes back to Rome, and then they need to stay in Rome for longer, approximately a couple of months between the screening and the treatment. But what we will do next, and I will finish here, we are planning a multi-center international clinical trial to be able to reproduce our results, hopefully in all the other institutions that will participate to the study. And these are most of the institutions that express their interest and that will be involved in this trial. And we will enroll patients that relapse or progress after the first line of treatment, and that, as I mentioned before, will have received no more than 2 previous lines of therapy. And again, we will have to have a low disease burden. These patients will receive a reinduction strategy at the moment of relapse to reduce the disease burden and to put the disease under control, hopefully and probably with chemoimmunotherapy. This will be the choice of each treating centers, but that's what we recommend considering the important results that chemoimmunotherapy is able to produce and that we are able to obtain nowadays. And we really think that chemoimmunotherapy and CAR T cells can synergize together to give a better control of the disease to our patients. And just to give you an idea, luckily, we are not the only one that are working on CAR T cells around the world. Many amazing groups are working on developing CAR T cell strategies to tackle this horrible disease. And as you can see, the most common antigen that is targeted is GD2, but there are other groups that are targeting other appealing targets like B7H3, GPC2, GPC3, or ALK. Here in the slides, you will see all the details of the study, all the details that are available. Most of the studies are phase 1 or phase 2, and most of them are in an early phase, so we don't know the results yet. There are studies that have published the results, but they're very few, and this is our study. As important note, you can find all the details of this study by looking at the trial number of the studies. And just to give you an idea, all of the studies are active in the United States. I reported only the studies from the United States and Europe because of the audience that is connected today. Most of these studies are from the United States, and only 3 studies are from Europe. Our study, which is this one, the Magneto study, which is this one that is from Gosh in UK, and this study here which is the last study, GD2 study, which is carried out in Germany. All the other studies are from the United States. And with this, I still just the last few seconds of your attention, because I really need to thank all the many people that are involved in such a challenging project, starting from the head of our department, Professor Locatelli, who had the vision more than 10 years ago that CAR T-cell could change the fate of our kids, and decided to invest money, resources, and really a lot of efforts on developing all the facilities and projects that we have developed. And we are really grateful to him, because without his vision, none of this would be possible. I would also like to thank all the clinicians and lab people and the people from the GMP facility that are working daily really hard to give these chances to our patients, and to give more and more chances to our patients. All the many people involved in the different clinical facilities that are working with us, all the people from the CAGT that helped us to set up these projects. Surely all the funding institution, because unfortunately the research is expensive and we need money to carry out all these projects. And so we are really grateful to our funding institution. But last but not least, a very special thank to all the patients and all their families, because they put their trust in us and give us the possibility to try to help them, and hopefully to help them more and more. And last but not least, thank you all for your attention. I'll be very happy to discuss with you and answer your question. So regarding the question, there are a few questions that were emailed before the seminar. So I will start from that, and then I will go through the Q&A session, where I can see that you posted a lot of questions as well. So one of the questions is a long question regarding an important aspect that I couldn't touch in the presentation, because as you can see, it was already a lot of data, but this is a very important. So thanks to the person that gave this question, because it gives me the opportunity. So the question is regarding the level of GD2 expression of CAR T cells that is required for the treatment, whether there is a threshold, and whether what is this percentage, and whether this can be can impact the activity of CAR T cells. Well, this is a very important topic. So until very few years ago, we didn't focus too much on the expression of GD2 on neuroblastoma, because it was well known that neuroblastoma is practically always GD2 positive. And so this was not included in our trial as a selection criteria. And indeed, of course, for research purposes, we anyway evaluated the GD2 expression in our patients. And until very recently, we couldn't find any patient who was having a GD2 negative neuroblastoma, neither before nor after the treatment with CAR T cells. A second aspect that is very important on this topic is that since it was not required for the treatment with monoclonal antibodies, and not even for our treatment with CAR T cells, a special technique that is reliable to test the GD2 expression has still to be defined differently from other antigens. So what is considered the gold standard is the flow cytometry technique, which is what we apply in our center, and we are using that. But what is completely unknown is what is the threshold, if there is a threshold of expression that can give a different activity of CAR T cells. And whereas it's known that for some antigen, the level of expression of GD2 is impairing the activity of CAR T cells, in our experience, this has not been the case. We have now identified a few patients before treatment that were GD2 negative, and so, or positive in a very low percentage of cells, like 10 to 15%. And in these cases, we excluded the patients from the treatment, because we were knowing that there was a high population of cells that was GD2 negative, and so that could not be recognized by CAR T cells. But the topic is still burning, And we are building in the SciUPenn a specific group to study this aspect, and we will have more and more information the more and more we study. In our center at the moment, we are studying this by flow cytometry, as I was mentioning, but we are setting up also other techniques to really study better this aspect, especially because we are seeing with the chemoimmunotherapy a higher number of patients that are becoming GD2 negative. And so we are starting to study this aspect. The second question is linked to what I just said. So I already replied, because they're asking how the GD2 expression is determined. And another question is, hypothetically speaking, what would you suggest if there is minimal residual disease after relapse, but the GD2 expression is 55% and the patient is in good clinical condition? Don't you think that there are too few cancer cells active to attack with T cells? Don't you need more disease to be able to have an effective treatment? So as I showed you now, in terms of amount of disease that is required to have a good response, actually, there is no need for high burden of disease to activate the T cells. They can get active also with very low number of cells. And as I showed you, we have treated 7 patients with no evidence of disease. So in theory, they didn't have disease, although we know that probably some few cells were remaining. Otherwise, these patients wouldn't have been at risk of having a relapse as they are. But in these cells, in these patients, we observed in almost all of them a high expansion and high activation of the CAR T cells, which means that there were some cells remaining, and that those few cells are enough to activate the CAR. In terms of percentage of GD2 expression, again, the matter is debated, and I cannot give you now a threshold that is able or not able to activate the CAR T cells, because we don't have this data yet with our CAR T. And so going back to the other questions, there are 2 questions about toxicities and insights on the long-term side effects. Are any of the toxicity you mentioned fatal based on the experience so far? So in terms of long-term toxicities, of course, this is one of our most important focus. So far, we don't have any of our patients that develop long-term toxicity. And in the pediatric population treated with CAR T cells in general, across not only neuroblastoma, which is mainly our experience, but also other studies like patients receiving CAR T cells for leukemia, the burden of long-term effects that can be attributed to CAR T cells, it's very low or limited. In our cohort of patients, we didn't have any toxicity that was induced by CAR T cells and remained over time. Of course, this cohort of patients is difficult to analyze because these patients are heavily treated, so most of them have long-term toxicity, especially lung long-term toxicity, pulmonary long-term toxicity, and we have been struggling with that. But we cannot say that this can be attributed to CAR T cells because it occurs at the same frequency as the patients that survive after conventional treatment. So we really believe that these are related to the conventional treatment. We focus a lot on the cardiac function because during CRS, the cardiac function can be impaired, but none of our patients had, and we will publish the data soon, none of our patients, even those that had a reduction of the cardiac function, has a persistent damage to the heart after CAR T cells. And in our experience, we didn't have any patients who died from CAR T toxicity so far. So none of our toxicity has been fatal. But of course, some toxicities can be challenging, and the experience of the treating physician in managing the toxicities is crucial to enable the toxicity not to become fatal. So this is important to say. So some toxicities can be important. Can this CAR construct, I go through the question again. Can these CAR constructs be adapted for endogenous T cell vector transduction to reduce the need of apheresis and the time needed for cell manufacturing? That's a very technical question, but very, very good one. So the in vivo creation of CAR T cells is still in very early stages of research. It's really, really a promising approach. There are people, as all the brand new things, some scientists strongly believe in that, and some scientists are strongly skeptical. the data are very early to give us a response to whether it could be really the future of CAR T cells or not. From my personal point of view, it's really appealing. So I really, I would really love to see a future where CAR T cells can be, even our CAR T cells can be manufactured in vivo, but it's too early to translate to this development. Is CAR T cell, thanks so much for the organization of the presentation. Thank you for the comment. Is CAR T cell expected to have effect on CNS neuroblastoma disease? What is the current status of the trial? Still enrolling patients? So the trial is has completed the recruitment, so it's still active for the follow-up of the patients, but it's not enrolling. But as I mentioned, we are still treating patients in the under a hospital exemption setting. Regarding the activity on the CNS, we have had 4 patients who had a previous relapse in the CNS before CAR T cells. It's not large numbers, so we need to be careful on the activity of CAR T cells in the CNS setting. There is this potential because we have seen CAR T cells in the circulating in the CSF, which is the fluid that is surrounding the brain. So CAR T cells can go into the brain. We have treated 4 patients, but so far we are only treating patients after the CNS disease is controlled with what today is the strategy that is giving the highest chances of survival, as was published by the MSK group in the CNS, which is in the administration of after surgery of craniospinal irradiation. So if patients receive surgery to remove the disease, craniospinal irradiation, they obtain complete remission, we can then administer CAR T cells. And in our experience, the combination of this treatment in our 4 patients is giving promising results. But the results are still too early to give more detail than this. Can I go again? Can I go on with the questions? There are a few more, or should I stop because of the time? Just let me know.
I think let's take 2 more questions, and then maybe if we have more questions, maybe we can reply on a different occasion.
Okay, so another question is, so in case of pure consolidation after achieving NED status, the EFS is 100% based on these results. Any plan of studying this scenario on a larger scale? So the EFS is not 100% because 1 patient relapsed. So it's 6 out of 7, which is in the order roughly of 85%, I would say. But you need to consider also that the follow-up of some patients is low. So we definitely need a longer follow-up to draw any conclusion. But we think that these results are promising. And of course, we want to further investigate on this scenario. Well, the next questions are basically connected to this. So they are asking me also whether in the multi-center trial we plan to include a site in the United States. It's in the future development for sure to move to extend also to the United States. Of course, changing regulatory bodies changes the work that the amount of work that we need to do. So at the moment, to be sure that we can move on, because already moving on with this project is requiring a long time, and we really want to give access to the treatment to the more children we can. At the moment, we are proceeding through multiple step process. So the first step will be activating European centers, but future step will include extra European countries, including at the moment it's Europe, UK, and Israel. But in the future, we will include also Canada, for example, Australia, Japan will be included as well. And of course, we will evaluate also the United States. That's it. Maybe I can answer to the question by email if people want to ask me, because then we have a lot more and I'm not sure that we have time. But I'll be happy to reply by email if people want to email me.
Okay, that's wonderful. Huge thank you, Dr. Del Bufalo, for your fascinating and so important session today. This research is the most advanced and promising hope, and we are all hoping for your success. Your dedication and advancing treatments and understanding neuroblastoma gives so many of our families hope. Seriously, so huge thank you. Looking ahead, we're excited to announce that our next webinar will be on April 7 with the focus of MSK, Memorial Sloan Kettering Clinical Trial Update and Vision. And I know many of you asked about, are interested in that, in hearing an update. So we'll have here Dr. Brian Kushner. He will share his knowledge and expertise, and you'll be able to ask questions. We hope you can join us for this conversation. Thank you again, and thank you for being part of this community as we continue to support each other on this journey. Thank you so much.
Thank you.